All right, our last speaker of the day is Ela Harris, and Dr. Harris is a professor at the medical school and adjunct professor at the College of Pharmacy at the University of Minnesota. She's on the faculty of St. Joseph's Family Medicine Residency Program as well. After obtaining her BS in Pharmacy and PharmD at Philadelphia College of Pharmacy and Science, she completed a residency in Family Medicine at the Medical University of South Carolina. Prior to coming to the University of Minnesota, she was on the faculty at St. Louis College of Pharmacy in, obviously, St. Louis. She is an active member of ACCP, formerly served on the Board of Regents. She's a fellow of ACCP. She was a recipient of the ACCP Ambulatory Care Practice and Research Network Achievement Award. She is also a former Specialty Council member of the Board of Pharmacy Specialties. Not anymore, that's why she can speak today. And she has served on and chaired numerous ACCP committees and is a past chair for the ACCP Ambulatory Care PRM. So welcome, Dr. Harris.
Good afternoon. We are going to switch gears here now. So put on a different hat and buckle your seatbelt, because we are not going to be talking critical care and pharmacokinetics anymore. My practice is in family medicine ambulatory care. And so now we're going to talk more outpatient treatment of some of these more ambulatory care type of disorders. And those disorders, we're going to do asthma, COPD, and gout, and adult immunizations. And some of these things have nothing to do with each other, but this is just what I was asked to speak on. So I have no conflicts of interest to disclose. And learning objectives are with regards to classifying patients, assessing control, selecting and monitoring treatment for asthma and COPD, as well as for patients with gout, and also determining appropriate immunizations for adults and applying cautions and contraindications and drug interactions. I'm not talking about pediatric immunizations that will be covered elsewhere. So starting with asthma, I think it's a very exciting time right now. I think that's not actually, this is my microphone, so I can walk around. It's an exciting time for asthma and COPD right now. And for those of you that don't do much in this area, there's a lot of new stuff. There's all sorts of new medications and new inhaler devices and things that make it a lot easier for patients to actually use their inhalers. So I'm having a lot of fun in my practice and switching patients over to a lot of therapies that make it easier for them. So starting with asthma, the presentation is different than COPD. There's cough that's usually non-productive. With COPD, it's usually productive. There is reversible airway obstruction that on spirometry after beta agonist treatment, you'd see a 12% increase in the FEV1. And the cough is worse at night and early in the morning, whereas COPD, it's throughout the day. And often asthma symptoms are related to allergies or environment. And with COPD, the most common coexisting factor is a history of smoking. There also is a new term for this condition that has been coined Asthma-COPD Overlap Syndrome. And this is because there's so many patients. Maybe it's that middle-aged patient who has smoked but has some symptoms consistent with asthma. Maybe spirometry looks more like asthma. And you know, you've probably all seen medical charts that have just both asthma and COPD listed, or asthma-COPD. And it's like, well, what does the patient have? Do they have asthma or COPD, and how do we treat them? So the GOLD, the Global Initiative for COPD, as well as the Global Initiative for Asthma, which is called GINA, they got together and they actually defined a disorder and named it Asthma-COPD Overlap Syndrome, or ACOS. And they have this criteria, and they set it out really easily, where there's these check boxes for features consistent with asthma or consistent with COPD, and you'd go through your patient and you check off which ones are more consistent as far as their age of onset, their pattern of symptoms, what their lung function is, lung function between symptoms, their family history, time course, chest x-ray, and you check them off, and you'd see which column you have more in. And in patients that have equal number in each column, then you would consider that they may have a diagnosis of ACOS. So the guidelines for asthma, there are two. There are the NH-LBI guidelines from the NIH, and there's also the GINA guidelines, and those are the world global guidelines. And in colleges of pharmacy and what we're teaching and what we're applying to patients are largely the NIH guidelines. Now, those have not been updated since 2007, but they are in the process of going through an update. Whereas the GINA guidelines are much more updated. But what I'm going to present to you is what we really use for patient care, and that is the NIH or the NH-LBI guidelines. And then I'll comment on a few things that are different in the GINA guidelines, some updates that we can apply to patients now. So in the NIH guidelines, there are different steps for assessing and determining treatment for asthma. The first step is classifying asthma severity. And the different severities are intermittent, mild persistent, moderate persistent, and severe persistent. And this is based on impairment and risk. And the impairment is how often they have symptoms, how often they awake at night with symptoms, how often they use short-acting beta agonists, and if it interferes with their activity and their lung function based on spirometry, looking at their FEV1 mostly. And then the risk is how many times they've had an exacerbation that requires systemic steroids in the last year. And if a patient falls into different categories, so for example, they're intermittent for symptoms, but they're moderate persistent for night awakenings, and then they're mild persistent for beta agonist use, and they're intermittent for interference with activity, and they're moderate persistent for lung function and intermittent for systemic steroids. See, they're all different categories. What you do is you use the most severe category, and that's how you would classify them. And I want to point out, too, that the symptoms and beta agonist use, you don't count the beta agonist use prior to exercise for exercise-induced asthma. You only count when the patient is using beta agonists to treat symptoms. So if someone exercises twice a day and they have exercise-induced asthma and they use their albuterol twice a day before their exercise, but they don't need it any other time, you do not count that twice a day in their beta agonist use. And another thing I want to point out is that some people are really good and their asthma is really well controlled in between exacerbations, but then they have two big exacerbations a year. Maybe they have one in the spring when allergy season starts, and they have one in the winter when it's really cold, and they require systemic steroids. But in between, whether or not they're on therapy, they don't even use albuterol, their symptoms are great, they still would have persistent asthma, even if the impairment piece all falls under intermittent, but then they have two exacerbations a year. So even if only one of them meets the criteria for persistent asthma, they still are categorized as that, and they would need controller therapy. And the twos are all red because a nice way to remember these different categories and how someone's pushed over from intermittent to persistent asthma is the rule of twos. So if someone has symptoms more than 2 days a week, they have a night awakening more than 2 days a month, and they have beta agonist use more than 2 times a week, and they have systemic steroid use 2 times or more a year, then they have persistent asthma and would require a controller. And there's one other little way to remember this too, in that if someone is well controlled with their asthma, they should not use more than 2 albuterol inhalers in a year. That would be indicative of well-controlled asthma. And you can see that in this chart, once you've categorized the patient, so someone with moderate persistent asthma, then you drop down here, and this is the first step of treatment that you would initiate. It's not a start low and go slow. It's you start treatment where you are at your severity level. So the next step, after you've assessed the patient's asthma severity, and you start them on therapy, then they come back, and then you assess their control. And there's 3 categories of control. There's well-controlled, not well-controlled, and very poorly controlled. And this chart looks similar there's a lot of 2s there. The categories are very similar. There's symptoms, nighttime awakenings, interference with activity. There's one additional row here, and that is the ACT, that's the asthma control test. And once someone has asthma and they're started on therapy, at every single visit in our clinic, and I'm not in a pulmonary clinic, I am in a family medicine clinic, every patient fills out paperwork and gets an ACT score. So at every single visit, even if they're not coming in for asthma, we assess their ACT. So that is another important criteria that's added for assessing a patient's control. And then you reassess their exacerbations, how many exacerbations have they had in a year. And then once you've determined the patient's control, then you have an action here. So if they're well controlled, you continue the same regimen, follow up in 1 to 6 months. And this part we sometimes forget to do. If someone's been stable for 3 or more months and they're doing really well, we can step down on their therapy. And the thought sometimes is, well, they're doing well, why would I step down? Well, they might not need as intensive a therapy in time. If a patient's not well controlled, then you would step up 1 step and follow up in 2 to 6 weeks. If they're very poorly controlled, you could consider a short course of oral steroids, step up 1 to 2 steps, and follow up in 2 weeks. And these are the steps that they're talking about. And this is all for adults right now, what I'm talking about. All 3 of these charts are different for children age 5 to 11. The adults are 12 and up, and then there's another category age 0 to 4. And in your workbook, in your handout that's the chapter, there is a table that includes all of the age categories, and each of the criteria, each of the treatments, it's all a little bit different. So this is only for adults. Okay. So step 1 is only for intermittent asthma, and that's just a short-acting beta agonist as needed. Step 2, we start with low-dose inhaled steroids. Step 3, low-dose inhaled steroids plus a long-acting beta agonist or medium-dose inhaled steroids alone. Step 4 is medium-dose inhaled steroids plus a LABA. Step 5 is high-dose inhaled steroids plus a LABA. And then malazumab is a monoclonal antibody for patients with allergic asthma, and that is a consideration in steps 5 and 6 in adults with allergic asthma. The alternative treatments are down here. Because the guidelines are older, they still list theophylline, but I can't remember the last time I saw an outpatient using oral theophylline. So that's not really used anymore, even though it's still in the guidelines. The LTMs are the leukotriene modifiers, and so those are alternatives in patients who have maybe younger children or patients who, or even older people who have trouble or difficulty using inhalers because it's available orally, and it's also add-on therapy as well for an alternative therapy. So each of those steps, they mention low dose, medium dose, and high dose inhaled corticosteroids. And just to make it more difficult for everybody, you have to have specific doses for each of those categories for each of the different inhaled steroids. And so here are all the different inhaled corticosteroids that are available. And here are the micrograms per day for the low dose, medium dose, and high dose. And most of them are divided BID. Most of them are, you might use 2 puffs BID, so you have to divide by 4 if you're trying to figure out how many puffs the patient's going to use, of which strength, and twice a day. And most of them come in multiple strengths. So it's kind of complicated. But once you figure it out and once you do it, it's not that bad. So there is the newest inhaled steroid is Arnuity Ellipta, and that is fluticasone furoate. And it is actually a once-daily formulation of fluticasone, which is a nice advantage for this fluticasone. Okay. So get your cards out. Our first case is a 23-year-old woman, and she has been coughing and wheezing twice weekly and 3 times a month at night. She's been using her boyfriend's albuterol, which is so common. They come in and they've never been to the doctor for their asthma, but they're using their spouse, friend, significant other's albuterol. Her activity is not limited. So she gets a spirometry in clinic today, and her FEV1 is 82% predicted. How would you classify her asthma? I'm seeing mostly Bs, mild persistent. Okay. So we look at this chart again. So she's having symptoms 2 or less days a week, but her nocturnal symptoms are 3 times a month, so she falls into that category. No interference with activity, and lung function is normal. And yes, you can still have asthma and have normal lung function, which we should sometimes remind ourselves of. So you go with the most severe category, which is mild persistent. So the correct answer is mild persistent B. So what medication is best to recommend for this patient, mild persistent asthma, in addition to her short-acting beta-agonist of albuterol? So you might need to look at the dosing of the steroid and the dosing table to see what's appropriate. I'm seeing mostly C's. Mometasone. Okay, so she's mild persistent, and this treatment step to initiate is step 2. And step 2 is low-dose inhaled steroids. And we go back to this chart. Low-dose mometasone 220 a day is considered low-dose inhaled corticosteroids, so the answer is C. So moving on to case 3, at first her symptoms are controlled, but she lives in Minnesota, and now winter has arrived. So it's been pretty cold, and now she's having symptoms and using albuterol 3 to 4 days a week during the day. And what is a preferred treatment change with this increase in use? Okay, I'm seeing a lot of D's and a couple other choices. Okay, so now we're at the step where we've started her therapy and now she's coming back, so we're assessing her control. She is having nighttime awakenings 1 to 3 times. Oh, wait, I had that wrong. I circled that wrong one. Sorry. It's daytime symptoms more than two days a week. So the circle just went in the wrong place. So she is not well controlled based on her daytime symptoms. So you would step up 1 step. She is currently at low-dose inhaled corticosteroids, so we move up to step 3, which we have a choice, and it's probably easiest to use what she has and move up to medium-dose inhaled corticosteroid and just have her take 2 puffs of her mometasone inhaler. So the correct answer is D. So now we're going to switch gears, and I'll walk you through this one since we haven't talked about it. And again, these tables are in the chapter, not in the slides, but where you have the full chapter. We have an 8-year-old boy has daytime asthma symptoms 1 to 2 times a week and is awakened twice a week at night with coughing. What is the best initial therapy for him in addition to albuterol PRN? Fluticasone 44 micrograms, 1 puff BID, Montelukast 10 milligrams daily, fluticasone salmeterol 100/50, 1 puff BID, or fluticasone 110 micrograms, 1 puff BID. So here is the same table, but it's for age 5 to 11. And for this age group, everything is actually the same, except there's some changes in this spirometry classification here. And instead of step 4 or 5, it's step 3 or 4 for severe persistent. So he's having symptoms 2 or less days a week, but night awakenings more than once a week, but not nightly. So he would be classified as moderate persistent asthma, which would be step 3. Now, this, for 5 to 11 years of age, is largely the same, except there's no omalizumab here because that's only indicated after age 12. And the other difference is in step 3, if you're starting at step 3, you would start with medium-dose inhaled corticosteroids instead of the combo low-dose inhaled steroids with long-acting beta agonist. So for him, we would start at step 3 in the medium-dose inhaled steroid, which is what would be recommended for him. And for the daily doses, these doses are largely different than the adult doses. And there's the addition of the budesonide for nebulizer use because young children may have difficulty with inhalers. So we would want medium-dose inhaled steroids, and the fluticasone 110 microgram 1 puff BID would fall into the correct range for this patient. Okay, so I'm going to briefly talk about inhaler devices, and you all know what meter-dose inhalers are. Those were the inhalers have been around forever. And then dry powder inhalers, there's single-dose dry powder inhalers, and then there's preloaded multi-dose. And those have also been around for quite a while, except for one new preloaded multi-dose. There's now newer multi-dose dry powder inhalers and breath-actuated dry powder inhalers and soft mist inhalers. So if you haven't practiced in this area for a while, then some of this might be new for you. I just wanted to mention here that all dry powder inhalers, no matter what type, the newer or older, all contain lactose and should be avoided in patients with severe hypersensitivity to milk or milk products. And no, this does not mean people who are lactose intolerant and get GI symptoms from milk, because that question comes up all the time. So meter dose inhalers I've listed here, and they're also in the chart that's in your chapter. All the different asthma and COPD treatments that are available as meter dose inhalers. And I've highlighted in blue the ones that are new, just to mention these, because mometasone, it used to be only a dry powder inhaler, the Asthma-Nex, but now there's Asthma-Nex HFA. And there's also a new one called Aerospan, which is flunisolide, and it has a built-in spacer. Kind of like a long time ago, you might remember Asthma-Cort. Some of you who have been practicing for a while, that had that big spacer that came down. Well, that had a CFC inhaler or a CFC propellant, and it had to switch to an HFA, and it's still the same drug, the flunisolide, but they've changed the device, and it now has an HFA, and it's got a smaller spacer. So these are the single-dose dry powder inhalers. There is a HandiHaler, which is what tiotropium or Spiriva is, and also, and that's a long-acting muscarinic agent. And there's also the Arcapta Neohaler, which is Indicaterol, which is a long-acting beta agonist. And these are single-dose in that you have a capsule of powder, and each dose you have to put the capsule into the device, click something to pierce the capsule, and then take a slow, deep breath. These are the preloaded multi-dose dry powder inhalers. The ones that have been around for a while are the Discus, which is fluticasone or Flovent, salmeterol or Ceravent, and fluticasone salmeterol combo, which is Advair. The Flexhaler is this one, which is budesonide or Pulmicort. The Twisthealer is mometasone or Asthma-Nex. And then the newest one is Tudorza Press Air, and this is aclidinium, and it's a new long-acting muscarinic antagonist. And with these are, unlike the dry powder inhalers and the single-dose dry powder inhalers, is that the breath that the patient has to take is very, very fast and quick and forceful, and it's difficult for patients to do correctly. So we haven't had a lot of success using these in practice because patients aren't doing them correctly, and then they can get confused with their short-acting beta agonist because it has a different technique, and we've had a lot of trouble with these. I'm very excited about this new device called the Ellipta device. And this opens like this, and that gets the dose ready, which is a dry powder dose. And it also counts down here in the counter. And then the patient doesn't have to press anything. All they have to do is take their breath in, and then this is a slow, deep breath, just like regular meter dose inhalers. It doesn't have to be very fast or quick or forceful. And a lot of patients who have trouble with meter dose inhalers are able to use this one correctly. And all of the available products that come in this Ellipta device are all once a day. And so these are all new. That's why they're all blue. They're all fairly new drugs. I mentioned the fluticasone furoate, which is our Arnuity, inhaled corticosteroid. There is a new long-acting muscarinic antagonist, umeclidinium. That's called Incruz. There is a new combo of fluticasone furoate and vilanterol. Vilanterol is a newer long-acting beta agonist, and this is the first combo of this that's available that's now once a day, just one inhalation once a day. And we have the first combo, there's one other one as well, but this is the first time that we have a combo of a long-acting beta agonist and a long-acting muscarinic antagonist. So it's umeclidinium and vilanterol, and this is called Anoro. The other new device is called a Respiclick, and this is the first short-acting beta agonist that's available as a dry powder inhaler. Until now, it's only been meter dose inhalers that have been available. So it looks like a meter dose inhaler, but it's actually dry powder. It's not an aerosol. And when the cap is pulled down, the dose is readied. And so the patient doesn't have to press anything down. All they do is put it in their mouth and take a breath in. And this also does not have to be fast, deep, and forceful. It can just be a regular, slow, deep breath, just forceful enough to actuate the dose. And this, I think, is another unique and new, and it offers a lot of advantages because the meter dose inhalers have been very difficult for patients to use because of that actuation and pressing down the canister, but they don't have to do that with this product. And this is also fairly new, and this is called a Respimat, and it's a soft mist type of device, and it's meant to mimic more of a nebulizer type of action, like a jet nebulizer sort of mist. And so even without an inhalation, the mist does go a little farther, whereas the other devices, it doesn't go anywhere if you don't take an inhalation. But here, it comes out as a mist, and you can kind of see that in this picture here. And so the patient just takes a slow breath. It's not a very difficult, not a real deep or forceful kind of breath. And they just press this button here when they take their breath. It is a little cumbersome to put it together. It comes separately with the canister and the inhaler, and it takes a while. You have to do several things and click it several times, but most pharmacies will do that for the patient. So it ends up being fairly easy for the patient. And so these products, the Spiriva or tiotropium, that's not that new, and the Compavent is not that new, but the newest ones are a new long-acting beta agonist, and that's Severity, that's olodaterol. And then there's another combination long-acting muscarinic antagonist with long-acting beta agonist, and that's tiotropium and olodaterol, and that's Stiolto. So now, this is kind of exciting too. This is pretty new. There's been a study that's been out for a little while, but finally the guidelines, so the GINA guidelines, now recommend using tiotropium, long-acting muscarinic antagonist, for the long-term treatment of asthma. For a long time, we treat acute exacerbations with ipratropium and albuterol together, and so it makes sense, and it's a bronchodilator, and there is excellent data now using the long-acting tiotropium in addition to their current medications in steps 4 and 5 for adults with severe asthma and history of exacerbations. So that's what the GINA guidelines recommend. There also is an FDA-approved indication for the Respimat version of the tiotropium, not the HandiHaler. And the Respimat has, the tiotropium has two strengths, the 1.25 and the 2.5. The lower dose is what's indicated for asthma, and the higher dose is what's indicated for COPD. So this Because the NIH guidelines have not been updated, this is not included in the NIH guidelines, but this is something that we can and you should and you can apply to practice because it's in the GINA guidelines. So I mentioned that ACOS, that combination overlap of asthma and COPD, and the recommendation for treatment if a patient does have ACOS is to use usually a combination of inhaled corticosteroids plus a long-acting beta agonist or a long-acting muscarinic antagonist. You don't want to use inhaled corticosteroids as monotherapy if they have features of COPD, because that's not one of the treatments. And you don't want to use a long-acting beta agonist as monotherapy if they have any features of asthma, because that has actually increased the risk of death in asthma when you use a LABA without an inhaled corticosteroid. So you want to use a combination. So asthma action plan. This is something that our community measures require it once a year in our chart. And so with all of our patients with asthma, we do an asthma action plan and make sure the patient has it in paper, that we've discussed it, and we review it and then redo it every year. And it used to be that asthma action plans were peak flow meter based. So each zone was based on what their peak flow readings were, and they would check their peak flows every day. But the guidelines say that you can use either peak flow based or symptom based, and since most patients aren't monitoring peak flows anymore, we do symptom based asthma action plans. So the green zone is when they're doing well, they're well controlled, they're not really having symptoms. So what you'd write in here for their asthma action plan is their controller, and then if they have exercise-induced asthma, then they would use their short-acting beta agonist prior to exercise. The yellow zone is they're having some symptoms. There's a really wide range of yellow zone. There's kind of like high yellow zone where they're just once in a while having symptoms, all the way down to low yellow zone where they're nearing a red zone exacerbation. But for the yellow zone, generally you're going to use 2 to 4 puffs of albuterol every 4 to 6 hours as needed, but you can repeat it in 20 minutes, and you can do that 3 times. It used to be that we would tell patients to double the dose of their inhaled corticosteroid for 10 days and then go back down to their regular dose, but they took that out of the latest version of the guidelines because that's not evidence-based. Now, in someone who's like really low yellow zone, that they're still not better after 4 puffs of albuterol, they can use up to 6 puffs if needed. So 1 hour after initial treatment of a yellow zone exacerbation, you want to look at response. There's either complete response, incomplete response, or poor response. And with a complete response, you could consider a steroid burst if their exacerbation was severe enough to begin with. If it's incomplete, you would repeat the short-acting beta agonist dose, and you would add an oral corticosteroid burst. And then for a poor response, you would repeat the short-acting beta agonist, add a steroid response or add a steroid burst, and then go to the ER, call 911 if the symptoms are still not controlled. And generally with the yellow zone exacerbation, we recommend continuing their short-acting beta agonist regularly every 3 to 4 hours for 1 to 2 days, and then switching to as needed. So red zone exacerbation is when a patient's having more severe symptoms and maybe they have a lot of trouble breathing, they can't work, they can't play, they're getting worse instead of better, and they don't feel like their medicine's helping. So in this case, albuterol 4 to 6 puffs, repeat every 20 minutes times 3, and then do a steroid burst. And you can do up to 8 puffs, depending on where you look and what guidelines you're looking at and what articles you're looking at. And what we do in our clinic, we actually do up to 8 puffs, and you can repeat that every 20 minutes times 3. And, when we tell patients this for the first time, you're like, what? I always just took my 2 puffs, and then I didn't think I could go anywhere above 2 puffs. I can take 8 puffs. Well, what are we going to do if they go to the ER? Give them lots of albuterol. So we can prevent an ER visit, by giving them lots of albuterol at home. And yeah, they might feel a little jittery, a little, tachycardia, maybe a little shaky. But you're going to treat their asthma and you're going to treat their exacerbation, and you can prevent an ER visit or even an office visit. And the way I tell people when I educate them about their asthma action plans is that it's not clear cut. Is this, yellow zone? Is this red zone? How much should you take? So generally, it's anywhere between 2 and 8 puffs that you can use. You just stop when you feel better. And then you can repeat it again in 20 minutes. And so if you're doing the asthma action plan and you have an oral prednisone burst for them for their action plan, then you have to give them a prescription ahead of time and tell them to fill it and keep the pills in their house. Because if they have an exacerbation at 2 in the morning and they have a prescription, it's not going to do them any good because they'd have to go to the pharmacy to pick up their prednisone. So it's just like one little information piece that's important for the patient. Okay, so classifying asthma exacerbations in the urgent or the ED setting, it's mild, moderate, severe, or life-threatening, and that's based on their signs and symptoms and then their FEV1. And this comes from the NHLBI guidelines, and it's going to be a combination depending on if it's mild, moderate, severe, or life-threatening, would be oxygen, inhaled short-acting beta agonists, and then oral steroids. If it's a severe exacerbation, oxygen, high-dose inhaled short-acting beta agonists plus ipratropium, plus oral steroids, and consider adjunctive therapies. And if it's life-threatening or impending respiratory arrest, then you might need to intubate the patient, and they might need to be on mechanical ventilation, 100% oxygen, nebulized SABA plus ipratropium, IV corticosteroids, and then adjunctive therapies. So there's as you step up for how severe the exacerbation is, your treatment is going to step up. So we have patient case 5. We have a 25-year-old male presenting to the ED with shortness of breath at rest. He's having trouble with conversation. He can't really talk because he's so short of breath. He used 4 puffs of his albuterol meter-dose inhaler at home with no resolution of symptoms. His FEV1 is checked, and it is 38% predicted. Which is the best initial therapy in the ED in addition to oxygen? I'm seeing a combination of C's and D's. So patient's having dyspnea at rest and is having trouble with conversation. And FEV1 is less than 40%, so he's having a severe exacerbation. So for severe exacerbation, you would use oxygen, high-dose SABA plus ipratropium, Q 20 minutes or continuously for an hour, and oral steroids, not IV steroids, and then consider adjunctive therapy. So the correct answer is D. Okay, so now we're going to switch gears just a little bit to COPD. There are the treatment and the assessment that we generally use for COPD are the GOLD guidelines, the Global Initiative for COPD. And these are updated every couple years. And the GOLD guidelines recommend considering COPD and performing spirometry in someone who is over 40 years old that has any of the following, even just one of them: dyspnea, chronic cough, chronic sputum production, and history of exposure to risk factors. And the most common is going to be tobacco smoke. And the criteria for diagnosis is symptoms and risk factors plus an FEV1 over FVC ratio of less than 70%. And you'll note that that is not criteria for the diagnosis of asthma, that FEV1 to FVC ratio. That's for COPD. So we have some validated symptom scales. We have the MMRC and the CAT test, and these look at symptoms, if they're at rest, if they're with activity, and how far the patient can walk, and how they feel their shortness of breath is. And the GOLD guidelines, they break down the categories of patient severity into groups A, B, C, and D. And you kind of like think about these as two separate categories, A and B, and C and D. Because A and B have the same FEV1 criteria. It's gold 1 and gold 2. So generally, it's their FEV1 is going to be 50% or greater. And then between A and B, A is less symptoms, and B is more symptoms. And that's based on these symptom scores. And if you don't have symptom scores in practice, because we don't tend to use these because a lot of these patients also have CHF, and we feel that there's some overlap with their shortness of breath questions that you ask them. So this, in practice sometimes this could be more subjective symptoms, how bad their symptoms are. But for a board question, it would be based on a symptom score. And then also you look at their risk, which is their exacerbations per year, and A and B have 1 or fewer exacerbations and no hospitalization. So contrast that with C and D. They have a more severe reduction in their FEV1, so it's basically less than 50%. And they have more exacerbations and at least 1 hospitalization. And again, C is less symptoms and D is more symptoms, but everything else is the same. So it's just based on these symptom scores. So principles of pharmacotherapy, and let me just explain, this red right here is not in your, maybe it is. This is in your current slide set, but it's not in your chapter. So this will be included in the published errata that, so any errors that come up in these presentations or books, there'll be a link to a document that has what the errors are in the book. So this is a little bit different in your book, but I will send Zangi a note about this, so she'll have this in the errata, and this is correct in your slides. Okay, so basically for COPD, there's not a lot of evidence, there's not mortality data, there's mostly it's symptom scores, reduction in exacerbations, improvement in FEV1. It's not mortality data. So we're really trying to make patients feel better, and we can't really prevent the decline in lung function that's going to happen with COPD. So initial treatment are long-acting bronchodilators, and in that category are included long-acting bronchodilators and long-acting muscarinic antagonists, or a combination of the two. And short-acting of both bronchodilators, either the beta agonists or the muscarinic antagonists, should only be used PRN. So someone with COPD should not be on ipratropium 4 times a day with the thought that, oh, that's kind of like a long-acting muscarinic antagonist because they're getting it 4 times a day. No, the evidence is that the long-acting agents have more evidence and should be used over regular use of short-acting bronchodilators. In moderate to severe COPD, long-acting muscarinic antagonists are recommended over twice-daily long-acting beta agonists because there's data that they can prevent exacerbations. Now, this is not included in the GOLD guidelines. This is in an updated recommendation from the American College of Chest Physicians and the Canadian Thoracic Society. And there is a large, excellent study called the POET-COPD study that showed tiotropium was more effective than salmeterol. And so now this is an official recommendation that in someone with more moderate to severe COPD, that they should be started on a long-acting muscarinic instead of a twice-daily long-acting beta agonist. There are some new once-daily long-acting beta agonists, and that's not included in this recommendation because they haven't been compared. And for short-acting bronchodilators in moderate to severe COPD, using a short-acting muscarinic antagonist like ipratropium is recommended over just using albuterol for PRN use. And the combination is recommended over just albuterol. So like a Combivent would be recommended over albuterol alone, or just ipratropium would be recommended over albuterol alone, and that's just for PRN use. Inhaled corticosteroids are added to long-acting bronchodilators in more severe COPD, only in patient groups C and D, only when the FEV1 drops below 50%. And there is not a dose response in COPD, or it's unknown, where in asthma we go from low dose to medium dose to high dose, and there's a documented dose response. We don't have that with COPD. So these patients should just be on an inhaled corticosteroid and pick a dose. It doesn't need to be a certain dose, but generally we tend to use a higher dose, medium to higher versus a very low dose. And there is a newer oral agent called Roflumilast. It's a phosphodiesterase 4 inhibitor. It's anti-inflammatory, but it's not a bronchodilator. And this can be added on in severe COPD in patients with chronic bronchitis and frequent exacerbations. So this table is from the GOLD guidelines and breaks it down for each patient group, A, B, C, D, and recommended first choice, and then alternative therapy, and then these are other kind of add-on treatments. And so notice that A and B, the FEV1 is greater than 50%, so there's no inhaled steroids in any of the treatment recommendations. When it drops below 50%, then that's when you see inhaled steroids in all the treatment recommendations. And I just wanted to add here that because it's not in the GOLD guidelines, it's not listed here that a long-acting anticholinergic is recommended over a long-acting beta agonist, but here in this it really should be first choice, second choice, now with the new recommendations from ACCP, that's American College of Chest Physicians, and the Canadian Thoracic Society. So we have patient case 6. We have a 62-year-old man with a recent diagnosis of COPD. Spirometry showed FEV1 over FVC ratio is 60%. Pre-bronchodilator FEV1 is 70% predicted, and post-bronchodilator FEV1 is 72% predicted. His symptoms are very bothersome. His MMRC score is grade 2, and he's had 1 exacerbation in the past year. Which is the most appropriate GOLD patient group to classify this patient in? I'm seeing mostly Bs. So we look at the criteria, looking at his FEV1 and 1 exacerbation and his MMRC score, he would be classified as category B. So the correct answer is B. So in this case, I have formoterol inhaler as a choice, but then now formoterol has been taken off the market, so it's no longer available. So your handout says formoterol, and your chapter says formoterol, but we'll just also think, or any other long-acting beta agonist. Okay, so in addition to albuterol, which of the following is most appropriate to initiate? And the other thing we know now is that with the newer recommendations, that none of these is really the right answer, right? So out of the available choices, which would be your most appropriate? I'm seeing some Bs. So according to the GOLD guidelines, patient group B, either a long-acting anticholinergic or a long-acting beta agonist would be appropriate. And then you can add the short-acting beta agonist as needed, but again, the newer ACCP CTS would recommend using either an ipratropium or a combination ipratropium albuterol as needed instead. So the correct answer out of all the choices that we have would be a long-acting beta agonist, but remembering that if a patient has more moderate to severe COPD, we'd recommend using a long-acting muscarinic antagonist over the long-acting beta agonist. And keep in mind, too, since there are these two recommendations, these ACCP/CTS recommendations are different than the GOLD recommendations. So whenever there's something like this that's available, there's two different recommendations that say two different things. A board exam question would have to say, according to the GOLD guidelines, according to the ACCP CTS recommendations. And if it doesn't, then that question probably would have to be thrown out later. Okay, so moving on to chronic azithromycin for prevention of exacerbations. There is some data in patients that are at high risk of exacerbations that there is some benefit of putting them on a low-dose daily azithromycin long-term to reduce the risk of exacerbations. And the results showed a longer time to exacerbation, to their first exacerbation. It was a 90-day difference, which was significant both clinically and statistically. There was a decreased rate of overall exacerbations. The number needed to treat to prevent one exacerbation was 2.86, which is pretty darn good. And there was also an improved quality of life. However, there were some adverse effects. There were hearing decrements that were quite a bit more common with azithromycin versus placebo, and that number needed to harm was 20. And there was also an increased incidence of colonization with macrolide-resistant organisms, which you would expect. And look at that difference, 81% versus 41%, and that was statistically significant. So in the ACCP/CTS recommendations, they actually suggest, not recommend, because they have two different categories. They recommend some things and they suggest some things. So they suggest long-term macrolides for moderate to severe COPD with one or more moderate to severe exacerbation in the past year and on optimal inhaled medications, and that is grade 2A. The GOLD guidelines do not recommend chronic daily azithromycin in any patient group. It's more of a case-by-case basis where you might consider it. So again, that's where there's some differences in the recommendations. So I mentioned briefly Roflumilast. The brand name is Daliresp. It's the only oral therapy for COPD, the phosphodiesterase inhibitor. And it is indicated to reduce the risk of exacerbations in patients with severe COPD with an FEV1 of less than 50% predicted with chronic bronchitis and a history of exacerbations. And the ACCP/CTS recommendations also suggest it for patients with moderate to severe COPD with chronic bronchitis and a history of at least one exacerbation in the past year. The GOLD guidelines don't have any specific recommendations or patient groups that it should be used in, but there is an indication, and this is just a suggestion, not a recommendation. I personally have not yet seen a patient on Roflumilast, but I have a feeling with these new recommendations, that maybe more people will be on it. So we have patient case 8. We have a 52-year-old woman with COPD. She has gradual worsening and shortness of breath over the past few years. Spirometry shows FEV1 over FVC ratio of 55%, FEV1 of 63%, CAT score is 10, never had a COPD exacerbation, and no steroids in 2 years. She's on tiotropium and albuterol. Which of the following is most appropriate according to the GOLD guidelines? Add salmeterol, add long-term azithromycin, add fluticasone, or DC tiotropium and start Advair. Seeing a couple A's. Okay, so looking at the GOLD guidelines, with this FEV1 and this number of exacerbations and this CAT score, patient is in patient group B. And the treatment, the first long-acting anticholinergic or LABA, and the patient's already on tiotropium. So then we go to the next step, which is the alternative choice, which would be the combination of the long-acting anticholinergic and long-acting beta agonist. And so the correct answer is A, add salmeterol, 1 puff twice a day. Or to make it easier for the patient, we could switch the patient to one of the newer inhalers that's a combination LABA-LAMA, such as Stiolto or Anoro. So managing COPD exacerbations. Short-acting albuterol is preferred, and that is given either via nebulizer or meter-dose inhaler with chamber. And generally also short-acting ipratropium is given. And in all patients with COPD exacerbations, they also should receive systemic corticosteroids. And the dosing is between 40 and 60 milligrams of prednisone for 5 days. There was some information that you had to do up to 14 days, but the evidence seems to show that the shorter duration of 5 days is not inferior to 14 days, so a shorter course should be sufficient. And then there needs to be an assessment whether or not antibiotics are given in COPD exacerbations. And this is looking at the cardinal symptoms of airway infection, which is increased dyspnea, increased sputum volume, and increased sputum purulence. And antibiotics should be given if patients have either all 3 of these cardinal symptoms, or if they have 2 of the symptoms, with one of them being increased sputum purulence. So if they just have increased sputum volume and increased sputum purulence, but not increased dyspnea, they still should get antibiotics. And then also if patients have a severe exacerbation requiring mechanical ventilation, they also should receive antibiotics. So that was loud. Optimal antibiotic therapy has not been determined, and it really should be also based on local resistance patterns. And so empiric antibiotics are used to cover the most common organisms, and it depends also if they have uncomplicated COPD, or if they have complicated COPD with risk factors, or they have risk factors for Pseudomonas infection. So there is a variety of different antibiotics that are generally used. So our case number 9 is a 64-year-old woman with COPD, and she's in GOLD patient group A. She presents with symptoms for the past few days of worsening shortness of breath and a productive cough with more cloudy and more copious sputum than usual. Her pulse ox is 95%. In addition to nebulized albuterol and ipratropium every 1 to 4 hours, which is the best course of action? Okay, I'm seeing many Ds. Remember that you want to use antibiotics if patients have all 3 cardinal symptoms, which she does. So the correct answer, and everyone with the COPD exacerbation should receive corticosteroids. So answer D is correct, oral corticosteroids as well as antibiotics. Okay, so now we're totally switching gears out of the pulmonary realm and switching gears into the rheumatology realm and talking about gout. The presentation of gout, it's usually acute, severe arthritis, and it's usually episodic, and patients may or may not have tophi. And with acute gouty attacks, there is severe, severe pain. It's been described that the pain is so severe that if you're laying in bed, you can't even have a sheet over your toe because it hurts so much, and the sheet just makes it excruciating. It's also been described as a patient lying in bed and someone walking across the floor like this. and the bed shaking just a tiny bit is enough to make the pain just excruciating. And I've had patients describe it to me as like the worst pain you can ever imagine, and it just debilitates them. They can't do anything. So this is not something to be taken lightly. It's very, very severe pain. And it's worse in the first 12 to 24 hours, and it can continue for a few days, but sometimes even weeks. The most common presentation, though, is just a few days, thankfully. It's most often in the lower extremities and in one joint, but it can have multi-joint presentations and can present in other joints as well. So predisposing factors is what a patient eats and how much alcohol they drink. And there's also some drugs that can increase the risk of gout, and usually by increasing uric acid, and also there's some medical conditions that can increase the risk of gout. So with gout, we also see hyperuricemia. And our target uric acid level is going to be different if a patient has tophi or doesn't have tophi. The target is less than 6 if they don't have tophi, and less than 5 if they do have tophi. And the first thing is to stop any non-essential medications that cause hyperuricemia. So hopefully no one's on niacin, but if they are, stop it. If they're on a diuretic for their hypertension, a thiazide diuretic, that's going to increase uric acid. There's many other options out there for them. So if that's not an essential medication, you would discontinue that as well. And urate lowering therapy, which generally is allopurinol, but also febuxostat, which is Uloric. That's the newer xanthine oxidase inhibitor. It's indicated in patients that have tophi. So if anyone has tophi, and even if they don't have frequent gouty attacks, but they have tophi, it's indicated. If they have 2 or more acute gouty attacks in the past year, it's indicated. If they have stage 2 CKD or worse, it's indicated. And if they have a history of past urolithiasis, it's indicated. And it's or. It's not and. So any one of those would indicate urate lowering therapy. There's a common misconception that you can't start urate lowering therapy during an acute gout attack. And these patients, if you don't start it when they come in for their acute attack, they're not going to come back to start it. And then you're dealt with a problem if you never start it unless you're treating an acute gout attack. So they don't tend to come in for their gout visits in between. Even if it's, come back when you're all better, they don't come back. And while urate lowering therapy can cause acute gout symptoms by mobilizing those uric acid crystals, if you're on treatment for your acute gout attack, then you're preventing that. So you can start urate lowering therapy during an acute attack. And this is from the 2012 American College of Rheumatology guidelines. They clearly state that, and it's completely fine to do. It's a misconception, though, that you can't do that. So first-line urate lowering therapy, allopurinol or febuxostat. And anytime you're initiating long-term urate lowering therapy, you have to initiate anti-inflammatory prophylaxis at the same time. Whether you're treating the acute attack, but then as soon as the acute attack is over, then you need to switch to maintenance therapy of anti-inflammatory therapy. And this is true for every single patient. So if they're not having an acute attack right now and you're just starting their allopurinol, you have to start anti-inflammatory therapy at the same time. If you don't, they are going to have an acute gout attack, and then they're going to stop their medication that you just started them on because they think it made their gout worse. Because it will. As soon as you start urate lowering therapy, there is an increased incidence of acute gout attacks. And that for sure will happen. So for anti-inflammatory prophylaxis, the first line choice is oral low-dose colchicine. Other first-line option is low-dose NSAIDs, but it's a lower evidence grade than colchicine, and it has more risks. And oral corticosteroids are an alternative only if colchicine and low-dose NSAIDs are contraindicated. However, that's another whole issue in itself. You don't really want to put someone on long-term oral corticosteroids either. So generally that's not used. This question always comes up, and this is from the American College of Rheumatology guidelines on gout. And the question is, how long do you continue this anti-inflammatory prophylaxis? And before these guidelines came out, it was hard to find this answer. How long do you really, you look it up in 10 different places, and they all tell you something different, and I don't know how long, and sometimes they give you a range of continue between 3 and 12 months, or between 3 and 24. I'm like, that's not helpful. Give me some more information on how long you continue. So it's very helpful, these ACR guidelines. They state that the anti-inflammatory prophylaxis with your colchicine, generally, should be the greater of any of these choices. 6 months, 3 months after achieving the target serum urate if there's no tophi, or 6 months after achieving their target serum urate if there were tophi, but now there's no tophi. But you would continue prophylaxis if there's any clinical evidence of gouty disease activity. So if they still have their tophi and they're not resolved, or they have gout attacks, or they have chronic gouty arthritis, you would continue their anti-inflammatory prophylaxis. So once you've started someone on your urate-lowering therapy, you want to monitor the serum urate every 2 to 5 weeks, and you want to start at a low dose and then titrate based on their serum urate, the patient's serum urate. After their goal is achieved, then you continue monitoring every 6 months. If you're on a single urate-lowering therapy, say allopurinol, and you titrate up to the maximum appropriate dose, which, by the way, for allopurinol is 800 milligrams a day. For some reason, everyone stops at 300 and will not go above 300. I don't know why that's in everyone's brain, but 300 is not the maximum dose of allopurinol. And this is the other shocker when I tell people, they often don't believe this, is that, you know how if you look it up on Micromedics and, based on this creatinine clearance to this creatinine clearance, you have to use this dose of allopurinol. And I'm sure, many of you have told a physician, oh, this allopurinol dose is too high because based on their creatinine clearance, based on what Micromedics says, so you should lower the dose of allopurinol. The American College of Rheumatology guidelines say those dosing recommendations are not evidence-based and should not be followed. That in CKD, you do have to be more careful and titrate up maybe not quite as high, but you still can use doses up to 300 and even above 300 in patients with CKD because you do also need to get the serum urate down. You just have to be more careful and do it more slowly and don't go up to as high of a doses. But some of those dose restrictions for the CKD, they're so specific, and you're on 50 milligrams a day if you have a little reduction in your creatinine clearance and someone's got a uric acid of 15, and that's not that helpful. So the guidelines say something different than what your drug references will say. So the next step, so if you've titrated up your single xanthine oxidase inhibitor to the max appropriate dose, then the next step is to add a urosuric agent. And probenecid is the first-line urosuric agent according to the ACR guidelines. However, losartan or fenofibrate are also uricosuric drugs, although they're considered second-line. But in our practice, most of our gout patients also have hypertension, so we just treat the hypertension with losartan. And then we don't have to start probenecid because we use losartan because it's you get a twofer if you treat your hypertension and you treat your uric acid. So if the patient's on 2 drugs and their uric acid is still not, their goal uric acid is still not achieved, then the recommendation is to add pegloticase. I'm not even sure if that's pronounced correctly. Pegloticase, I think. And this is an IV drug, and it's only for refractory patients or patients that are intolerant of other agents or really can't get their uric acid down, and they have severe disease. That would be the IV therapy that would be indicated next, but that's it's not used very often. And urate-lowering therapy should be continued indefinitely. Patients are like, oh, so how long do I have to continue it? Oh, my gout's better, so I guess I can stop it now. And a lot of people do stop it on their own when they feel better. And then unfortunately, when you restart it, they have another gout attack. So it is indefinite duration. Okay, so switching gears to treatment of acute gout attacks. I like to call this the gout action plan because, we have an asthma action plan, and we just don't want patients to come in every time they have a gout attack with their severe pain and they're hobbling in. That's no fun. So we like to make sure they have their treatment at home, that they fill and they fill the prescription, they have the bottle at home, and they can take it when they have their acute gout attack, and they have it written down so they know exactly what they're supposed to take. So that's my, I'm going to patent that or something. Can I do that? Copyright it? The gout action plan. So we really should be treating or initiating treatment within 24 hours of an acute gout attack, which again works best if the patient can start that on their own. And you can't really use colchicine if you start it after 36 hours after the initiation of the gout attack. During a gout attack, continue urate-lowering therapy without interruption. And if you don't tell a patient this, they might not do it. So it's like an extra educational step. Yes, we're giving you colchicine now for your acute gout attack, but keep taking your allopurinol throughout the entire gout attack because they have it in their mind that allopurinol can cause a gout attack or worsen their gout attack, and they think they have to stop it when they have an acute gout attack, and no, they should not. So that's a very important step. Do not stop the urate-lowering therapy during an acute gout attack. So you want to assess the severity of their gout attack and select the therapy based on the severity. So there's either monotherapy or combination therapy, and that depends on how severe the pain is and how many joints are involved. Monotherapy is either NSAIDs or oral corticosteroid, and no, you don't have to use indomethacin. Gout's a really old disease, and I think like indomethacin was like the first NSAID available or something, and so that was like the first one that people started using, and people still use indomethacin for gout. Like, no, you don't have to use this really old-fashioned NSAID. Your handout actually has a table that has the dosing for ibuprofen and naproxen, and yes, you can use some of the more modern NSAIDs and don't have to use indomethacin. Oral corticosteroids are also perfectly appropriate for monotherapy, and oftentimes we tend to use that more than NSAIDs or colchicine, because if there's risk factors or side effects from the other ones, a short burst of oral corticosteroids is pretty darn safe. So evidence A for either NSAID, oral corticosteroid, or colchicine. And something that you don't always think of, topical ice has evidence for helping pain from an acute gout attack. So tell patients to put ice on the affected joint. If a patient has received acute gout treatment with colchicine in the past 2 weeks, you want to use a different therapy. You don't want to repeat therapy with colchicine within 2 weeks. And per colchicine labeling, this is so not helpful, right? It says, used to treat gout attacks in patients with renal or hepatic impairment who are taking prophylactic colchicine is not recommended. Well, what do you mean by that? How much impairment, how much renal impairment? So, package insert stuff like this is not that helpful because I don't know how much impairment they're talking about. So how I interpret this is if it's more, moderate to severe, that you would start worrying about using acute gout attacks with colchicine if they're already on prophylactic colchicine. You can use intra-articular corticosteroids for 1 to 2 large joints. That's pretty easy to do. Patients don't always like it, though, because you're sticking a needle in their painful joint, so they don't often select that therapy. And you can do a single dose IM triamcinolone followed by oral corticosteroids as well. Those are all options. For combination therapy, you can do full doses of 2 or full dose of 1 and prophylactic dose of the other, and those doses are all included in your chapter. And the choices are colchicine plus NSAID, oral steroids plus colchicine, or intra-articular steroid with any other agent. But you don't want to use an NSAID plus oral corticosteroid together because of additive side effects. So we have a patient case. We have a 60-year-old man with his third gouty attack in the past year. His last attack was 10 days ago. He took colchicine with good response. His pain started 10 hours ago. It's in his left knee and his third and fourth left proximal interphalangeal joints. His pain is 6 out of 10. He also has COPD and dyslipidemia and normal renal function. His uric acid is 10 and he has no tophi. Which would be the best treatment of this acute gout attack? I'm seeing a lot of A's. Okay? So we would call this mild to moderate pain, one or a few small joints or 1 to 2 large joints. So monotherapy, not combination therapy. And an NSAID is one of the listed agents, and we don't want to use colchicine because the patient had another gout attack 10 days ago and received treatment with colchicine. So the correct answer is A, naproxen. Just some explanations on why those other choices are incorrect. So in this patient, which is the most appropriate regarding urate lowering therapy? So allopurinol or probenecid, and start now or start after the acute attack is resolved. He's had 3 attacks a year, so he needs to be on therapy. So I'm seeing D. So remember that allopurinol, not probenecid, is first line. And you can start during an acute gout attack as long as the patient's on anti-inflammatory therapy, which they are. So the correct answer is D. So which of the following regimens for anti-inflammatory prophylaxis in this patient is most appropriate once the acute attack has resolved? Is it colchicine, prednisone, colchicine plus naproxen, or pegloticase? I'm seeing mostly A. So first line is low-dose oral colchicine. So the correct answer is A. So now what is the initial goal uric acid and duration of anti-inflammatory prophylaxis in this patient? So he's got 3 involved joints and no tophi. And his uric acid was 10, I believe. Seeing a combination of A's and B's. So no tophi, so the goal is less than 6. And remember that it needs to be the greater of all of these choices. So in that 3 months after achieving the target serum urate, it still has to be at least 6 months because it has to be the greater. So if someone achieves their target serum urate in a month, you don't stop it after 4 months. It still has to be 6 months. So then the correct choice is B, because what if it takes 6 months to get to the goal? Then you have to continue it another 3 months. So choice B could end up being a longer term therapy. Okay. So adult immunizations. I don't have a huge amount of time, but it's tough to discuss adult immunizations all that much because it's a lot of charts and a lot of tables. The 2016 adult immunization guidelines are in your chapter, and it has all the charts. It has every single footnote. What I'm going to do is I'm going to go over the updates and some of the newer things regarding adult immunizations. So this is what the adult immunization chart looks like. Breaks it down for recommended or recommended depending on certain indications. And then also if someone has like certain medical conditions or other indications, when other immunizations might be recommended, and when they're contraindicated. So the major changes in the 2016 schedule, the first one's regarding meningococcal vaccine. There's a new vaccine for serogroup B meningococcal, and it's called MenB, and it's a new vaccine for patients 10 years old or older who are at risk of serogroup B meningococcal disease. And then in the guidelines, they have a list of what those risk factors may be. Now, this does not cover other types of other meningococcal serogroups. So the other ones, like MenACWY, cover serogroup A, C, W, and Y. And if a patient is at risk for A, C, W, and Y and B, then they would receive both of those meningococcal vaccines. And there is a typo which is going to be in your published erratum. It says no official recommendations for vaccination. It should be revaccination. So I corrected that in your slides, but it's the chapter that has that typo. HPV vaccine, there is a new one. There is a 9-valent HPV vaccine in addition to the currently available bivalent or quadrivalent HPV vaccines. And it's different regarding males or females. So the new 9-valent can be used in males and females. But for females, you can use bivalent, quadrivalent, or 9-valent, but for males, you can only use the 4-valent or 9-valent. You can't use the bivalent. And the other new change is that the 23-valent pneumococcal polysaccharide vaccine, or PPSV23, or Pneumovax, is no longer recommended for people in nursing homes or long-term care facilities. It used to be indicated that all those people should get Pneumovax, and that's no longer recommended. So the 2016, the new updates, there's not anything super exciting. I think last year and the year before, there was some more exciting stuff. So I'm just going to highlight some of the other newer adult immunization issues that came out in the last couple years. And one is regarding the use of Prevnar for adult immunizations. This was previously only indicated for pediatric patients in the pediatric immunization schedule, but last year it was added for adult pneumococcal vaccination. So all patients that are age 65 and older should receive the Prevnar or the pneumococcal, the PCV13, not the Pneumovax is PPSV23. So all adults should also receive the Prevnar in addition to the Pneumovax. And it's complicated in how you give it and when you give it. It depends if it's a pneumococcal vaccine naive patient, then you give the PCV13 and then follow it by the PPSV23 12 months later at least. It used to be 6 to 12 months, and then they changed it mid-year to 12 months later. If someone had an indication for previous pneumococcal vaccine and they received it, they already received it at 65 or older, and now they're, let's say, 70, but they already had the Pneumovax, then you would just give them the Prevnar, the PCV13, and it has to be just at least a year after receiving their Pneumovax. If a patient received Pneumovax before age 65 because they had asthma or COPD or they smoked or had diabetes, another indication for it, but now they're over 65 and it's been at least a year since they received the Pneumovax, then they should receive the Prevnar, the PCV13, and then at least a year later, as long as it's been 5 years since their previous Pneumovax, then they should get Pneumovax again. And I'm telling you that this little chart here, I've looked at that so many times because when it comes up, it's like, oh, wait, I have to think about this. What did they get? How old are they? When did they receive their last one? When did they get Pneumovax before? Did they not get it before? So it is kind of complicated, but this is important to know that schedule because it's something that every single patient over 65 needs to get. So the early pneumococcal vaccination of the Pneumovax for PPSV23 was with chronic heart disease, chronic lung disease, chronic liver disease, alcoholism, diabetes, and smokers aged 19 to 64. And it depends on some additional conditions that they have. If they're going to get, they might also get an early Prevnar dose before age 65 if they have asplenia or they're immunocompromised, and they have cochlear implants or CSF leaks. So there are some indications where adults may get the Prevnar before age 65 as well. Quickly, the question always comes up about egg allergy and influenza vaccine, and in the last 2 years, there's been some updates and some changes regarding influenza vaccine and egg allergy. If a patient has any severity of egg allergy, they can receive the recombinant influenza vaccine, which is the RIV, because it has no egg protein. It doesn't use eggs at all. If a patient only had hives after eating eggs, then they can use any of the inactivated influenza vaccines as long as they are observed and they have additional safety measures. They should not use the live intranasal influenza vaccine. And then remember that some people who report egg allergies might not actually be allergic to eggs. If someone can eat lightly cooked eggs, like scrambled eggs without a reaction, they're not likely to be allergic and they can receive any influenza vaccine. Tdap, this recommendation came out a few years ago now, maybe in the last 5 years, and everyone age 11 and older should receive Tdap at least once. If someone doesn't know their previous Tdap vaccination status, they should get a dose of Tdap. So they have their initial Tdap vaccine, and then that's followed by just the TD, the tetanus booster, every 10 years. And a few years ago, they added that all pregnant women should get a Tdap during each pregnancy, preferably between weeks 27 and 36. So each time, if they got pregnant every single time they get pregnant, they need another Tdap. If they have 10 children, Tdap with every single pregnancy. And this is to protect not the mom, but it's to protect baby. And a Tdap can be given regardless of the number of years since a prior tetanus or Tdap vaccination. Zoster is one of these vaccines that the evidence isn't great. They are studying a newer one that hopefully will have better efficacy. And this also, we have trouble having patients paying for it because it's covered under Medicare Part D and it's not covered under Part B, so you can't really give it in the clinic and it's not paid for, and so a lot of pharmacies are dosing it. So it's just a little complicated, it's a little different than the other vaccines. But it is indicated in all adults 60 and older, and even so the FDA says 50 and older, the CDC or ACIP recommends it only in 60 and older. And a patient can get it whether or not they had a previous infection of or episode of zoster. And just briefly mentioning, there's some confusion whether zoster can be given concurrently with pneumococcal vaccination or they should be separated by 4 weeks. The package insert says don't give concurrently, but the CDC says you can give these two concurrently. So we would go by what the CDC says versus what the package insert says. We talked about the HPV vaccine. It is recommended at age 11 or 12 or between age 13 to 26 if they weren't previously vaccinated at age 11 or 12. And it can be used in men up to age 21 but older in certain men. And ideally you want to give the HPV vaccine prior to sexual activity, but the question comes up, well, if they're already sexually active, should you still give it to them? Yes. And if you've already had an HPV infection or genital warts, should you still vaccinate them? And the answer is yes. If they've had an abnormal PAP, any of those things, you still can give them the HPV vaccine. And I have 1 minute left, so I'm going to quickly move to the cases. We have a 71-year-old woman with COPD, and she's taking tiotropium inhaled once a day. She got the influenza vaccine last October. Her last TD was at age 65, and her Pneumovax was at age 60. And she's not previously received zoster, but had a severe zoster infection 5 years ago. So which of the following vaccines should she receive at her October clinic appointment? I'm seeing a lot of Ds. Okay, so the reason she got the vaccine, the Pneumovax early, was because of her COPD. And so now, because she's over age 65, she should get the PCV 13 today. And zoster, because she's 60 and older. And even so, she had a previous episode of zoster. And Tdap is for everyone, no matter how many years since TD. So D is the correct answer. And 20-year-old woman who is going away to college, living in the dorm, smokes half a pack a day, no other medical conditions. She's up to date with all her routine childhood vaccines, no vaccines in 11 years. She's not sexually active. Which should she receive? Now, I did skip over the meningococcal recommendations. So young adults who are going away to college and living in the dorms should be vaccinated with the meningococcal vaccine, MenACWI. So first-year college students age 21 or less living in dorms, vaccinated if they have not received a dose after age 16. She's a smoker, so she needs pneumococcal vaccine and HPV vaccine because she has not received it before, and Tdap for everyone. So the correct answer is D. And I will just tell you the correct answer here. It has to do with egg allergy, angioedema, difficulty breathing. The correct answer here is only recombinant influenza vaccine. So the correct answer is C. And here's my email address if you have any questions that you think about later and you need to email me, and I will hang out here if anyone has any questions. Thank you.